Today we're going to be talking about Ards, Acute Respiratory Distress Syndrome, and all of the clinical manifestations and nursing care for patients with. In terms of a definition, acute respiratory distress syndrome is a sudden progressive form of acute respiratory failure. It is essentially a filling of the alveoli. The alveoli actually fill with fluid, and we cannot complete gas exchange, and then we have all the clinical manifestations associated with ineffective gas exchange. Where does it come from? Well, we don't really know. The most major cause, the most common cause, we can say is sepsis. We can say that it is an end result of sepsis when we start to have actual lung tissue damage. But it can come from a variety of direct or indirect lung injuries. It is absolutely part of the inflammatory and immune response. We talked previously about sepsis, SIRS, Ards, SIRS and MODS being the inflammatory system going wild, so there is some sort of an insult to an area of the lung, and then inflammation, the inflammatory process takes hold, and it is driving the entire driving the person to respiratory failure. Take a look here at this slide. I'm going to give you a general overview using this particular slide. If you look at A, figure A, you see that you have a normal alveoli with no fluid. It has a capillary, a pulmonary capillary surrounding it, and between the pulmonary capillary and the alveoli is what we call the pulmonary interstitial space. In figure B, when we talked about sepsis, we talked about the inflammatory response, the mast cells releasing histamine. And when the mast cells release histamine, they cause gaps in the vascular wall. And when they cause those gaps in the vascular wall, we are allowing protein-rich or albumin-rich fluid to leak out of the pulmonary capillary space, and it leaks into the interstitial space. Well, that's okay. It can leak into there, but eventually, when the inflammatory response continues to build, there is no mediator, there is nothing to inhibit it, the interstitial space becomes so full of fluid that the fluid has nowhere to go, so it moves into the alveoli. So then we move to figure C. So we have an inflammatory response, an out-of-control inflammatory response, which is causing the release of histamine from the mast cells, and that release of histamine is causing the vascular space to have big gaps, and because of those gaps, protein-rich, albumin-rich fluid is leaking into the interstitial space, and then it moves into the alveoli. You can see in figure C that it's about halfway up the alveoli. So we still have some area for gas exchange. But as Ards continues, as this acute respiratory distress syndrome continues, eventually the alveoli fill and there is no area for gas exchange. What are the clinical manifestations? What does it look like? What is the end result? Severe dyspnea, hypoxia, decreased lung compliance, and diffuse pulmonary infiltrates. It is got a very high mortality rate, yet the incidence of Ards is not very high. 150,000 cases annually means that it's not something that's common to see, so that if you are seeing it, you are probably in a critical care setting, and it is something that you are excited to see and learn about, even though it's kind of devastating when the person gets it. I do not need you to know all of the stages of Ards. I don't want you necessarily to understand the injury and reparative phase. I want you to understand as a concept what is happening. So what we're going to go through here, I'm going to go through and I'm going to talk to you about generally the progression of the disease, even though these slides are giving you the initial injury period is 1 to 7 days. That's not really important. But what is important is I'm going to remind you of the inflammatory process. And we said that during the inflammatory process, the mast cells or the basophils release histamine in response to inflammation. The neutrophils become sticky, and by that we mean that they begin to clump together. So we have the initial inflammatory response, and we have histamine being produced. Histamine is dilating the vessel. Histamine is causing gaps in the vascular wall, which is allowing fluid to leak out of the vascular wall and is filling the alveoli. At the same time, we have the basophils, or the neutrophils, which are going, and the neutrophils are trying to adhere to those gaps in the vascular wall. So the neutrophils are plugging up these little spaces along the way, theoretically. But then on top of that, we have platelets. And we have platelets which are going on top. So we have, when the neutrophils adhere to the wall, we say that's margination. When the platelets cover the neutrophils and make a big clot, we call that pavementing the vessel. But if you can imagine that alveoli, the pulmonary capillaries that are moving around the alveoli, well, we have lots of fluid leaking into the alveoli, which is causing the alveoli to fill up. And then we have all these tiny blood clots that are getting inside of the vessel. And these tiny blood clots inside of the vessel make it very difficult for the blood to flow around. And even if there was an opportunity for gas exchange, now the blood has to try to maneuver around all these blood clots. In addition to the blood clots forming, the alveoli filling, we are saying that there is increased capillary permeability from the histamine. We are saying there is formation of the pulmonary microemboli, and that is because we have the neutrophils covered by the platelets causing all these little microemboli along there. And we say there's pulmonary artery vasoconstriction. Well, as the condition increases and the fluid is moving out of the vascular space into the alveolar space, we develop what we call an intrapulmonary shunt. And what that means is that the blood passing through cannot be oxygenated. So could you imagine, we have this, referring back to that initial figure A, B, and C, could you imagine we have blood coming in figure C? So it's coming in the one side, it comes into the one side of the alveoli, and the alveoli is full of fluid, and there's all kinds of microemboli along there. Well, even if the blood makes its way around, it wants to do gas exchange. So it wants to release carbon dioxide, and it wants to gain oxygen. But unfortunately, it can't do that. There is no oxygen in those alveoli. It's only fluid in there. So we say there is an intrapulmonary shunt. So the blood has come out of the right side of the heart. It's come into the right, from the body into the right atrium, and from the right atrium into the right ventricle. It leaves the right ventricle, and it wants to go down, and it wants to take that blood into the capillaries around the alveoli, and it wants to release the carbon dioxide, and it wants to gain oxygen. But there's no oxygen to gain. But the blood continues to maneuver its way around all these little obstacles, all these little blood clots, and it finally makes its way back to the left side of the heart. But the problem is, it didn't have any oxygen. It didn't pick up any, or it picked up very little oxygen in the lungs. So now the blood is moving from my left atrium, where it's normally oxygenated, and it's not now, and it's moving from the left atrium to the left ventricle and out the aorta, and the aorta is trying to perfuse all the end organs, my brain, my heart, my lungs, my liver, my kidneys, and I don't have the oxygen to do it. So when we say that we have ARDS, it is a condition of inflammation in the lungs. But you can see very easily how as ARDS progresses, ARDS can turn itself very quickly into MODS, multiple organ dysfunction syndrome, because those other organs are going to begin to have dysfunction because they don't have the oxygen that they need. In addition to the alveoli filling because there's fluid leaking out of the vessels, in addition to all of these blood clots being formed inside of the microvasculature of the lung, we also have a problem where, when we have inflammation in the lung, we have a surfactant dysfunction. And by surfactant dysfunction, I mean that the alveoli have a difficult time expanding. You'll recall that surfactant decreases the surface tension of the alveoli. So when we think about surfactant, we think about a balloon. If you get a brand new balloon out of a package and try to blow it up, it's very, very hard to blow up. You have to have a lot of pressure to blow up that balloon. But if I add surfactant to it, it would be like blowing up a balloon that you have blown up 50 times. It blows up very easily because it has very little surface tension left. So when we say that during the inflammatory process inside the lungs, we have a decreased surfactant production or a surfactant dysfunction, then we are predisposed to atelectasis. So we have the alveoli that are filled up with fluid, and even the ones that aren't filled up with fluid yet, there is a surfactant dysfunction, so it's very, very difficult to blow those alveoli up. So some are filled with fluid, some are collapsing because of their surfactant, further putting the patient at risk for MODS. We call that a VQ mismatch. And by VQ mismatch, I mean this. VQ, ventilation perfusion. When we are talking about ARDS, we are doing a VQ scan. So no matter how much oxygen I give this person, their oxygenation status does not improve. So I put you on 100% non-rebreather, and you were at 85 was your O2 sat. I put you on the 100% non-rebreather, and you're still at 85. Because it doesn't matter if I give you 2,000% oxygen. If the blood can't make its way around in those capillaries because of blood clots, if the alveoli are full and the other alveoli are collapsed, I have that intrapulmonary shunt, and it doesn't matter how much oxygen I give you, you are not improving your oxygenation status.
Okay, here is a slide just talking about some of the things that we just talked about, the severe VQ mismatch and the shunting of the pulmonary blood resulting in the hypoxia, which is what I just said, but I have it here on the slide for you, and unresponsive to the increasing O2 concentrations. So that is, as we were talking about, I could put you on 100% non-rebreather with your 85% O2 sat, and because of the VQ mismatch, which means no matter how much oxygen I give you, you don't respond, and you're not responding because there is shunting of that pulmonary blood. The blood is moving from that right ventricle and it is unoxygenated. It's passing through the rich capillary beds, but they have the microemboli. The alveoli are filled with the oxygen, and that way, that's what we call that pulmonary shunting, the VQ mismatch. They're unresponsive to increasing amounts of oxygen. In addition to that, making that VQ mismatch further complicated is that the lung is less compliant because they have that surfactant dysfunction. Okay, so because of that pulmonary shunting, the work of breathing is increased. They are trying very, very hard to oxygenate themselves, and their respiratory rate is up. Their tidal volume is down because of all of the atelectasis that they have. And in the beginning, they have a respiratory alkalosis because they are breathing as fast as they can, and they are blowing off all that CO2, which results in respiratory alkalosis. And as the work of breathing becomes more and more, it turns to respiratory acidosis because their rate is slowing down. They're exhausted. And we get that respiratory acidosis because they're holding on to that CO2. So we have a decrease in cardiac output. And because of that decrease in cardiac output, the amount of blood returning to the left side of the heart is reduced, decreasing the cardiac output. And with decreased cardiac output, we have altered tissue perfusion. So
okay, and then we go through the reparative phase, or proliferative phase, where it's either time for the person to get better, or the person is going to become move to an irreversible state where they cannot improve because their lung compliance is down and they're developing so much scar tissue in there. And that's kind of what happens. We have all those neutrophils and monocytes and lymphocytes, and hopefully we can get a hold of the inflammatory response. But if we can't, it just gets worse and worse, building up until it eventually leads to MODS. Again, you're going to see the phases on here, but I don't think it's important that you memorize the phases. Just go with saying as being important. So we have thickened if the condition is not going to get better, like if we don't turn it around, scar tissue is going to develop. We're going to have thick alveolar membranes, and thick alveolar membranes are not conducive to good gas exchange. And we're going to have widespread fibrosis, and hopefully the person doesn't die, but there's significant lung damage at that point. The final stage is the fibrotic or the chronic, the late phase, where there's pulmonary hypertension. There's very little areas for gas exchange. The areas that are thick and not conducive to gas exchange. So there's wide changes and remodeling of the lung tissue, and we have vascular destruction, and it's very late and very ominous. People who make it to that stage. Okay. Some persons survive the acute phase of the lung injury, but as you move through, long-term survival is not likely. Of course, we always do have mechanical ventilation, but that's always got a lot of issues associated with quality of life. Clinical manifestations early on: dyspnea, tachypnea, cough, restlessness. Of course, we know that as pulmonary congestion, as pulmonary edema is becoming more and more prevalent, that we are going to have the person going to have the J receptor stimulated, so they are going to start breathing away as much as they can. They're going to be coughing because they've got congestion down there. They're going to have dyspnea, and of course agitation and restlessness is going to be a problem. Now, when you listen to the lungs of these people, they may be normal in the beginning, but then you might, and the reason it may be normal in the beginning is because these infiltrates, when you get pneumonia, normally you'll get a chest x-ray and they'll say like a right lower lobe pneumonia, a right lower lobe infiltrate. And that'll mean there's a little spot down in the right lower lobe or wherever else it is that has pneumonia, but everything else is kind of trucking away and doing what it's supposed to do. You have to remember that Ards is a inflammatory response in the entire lung. So you might have a handful of alveoli affected over here and a handful over there, some in the bases, some in the apex, some in the middle lobe. So it can kind of be everywhere. So initially when you listen, you might not hear anything. Or you might be listening as it gets worse and you're hearing like you don't normally, when we listen to lungs and somebody has pneumonia, you normally hear it, you could hear wheezing throughout, but you normally hear it in one spot. You don't normally hear everywhere you put your stethoscope, the lungs aren't congested, and that might be what you hear later on. Initially, in the early symptoms, getting ABGs is going to be critical. We might have some mild hypoxemia, some respiratory alkalosis because of the hyperventilation, which we talked. Chest x-rays may be normal because it's so small that we can't really detect it, or we'll see these scattered interstitial infiltrates. And you might not see edema until 30% increase in lung fluid content. Now that's a lot. When 30% of your alveoli are used up, and that's when we begin to see it on the x-ray, that person's already, we call it the early stages, but you can see how significant an illness this really is. As the symptoms progress, we have more fluid accumulation, we have less lung compliance, we have more pavementing in the vessels, so we have difficulty for the blood moving through the alveoli. We have that intrapulmonary shunting happening, and so there we have a lot of discomfort, a lot of work of breathing. Very much decreased lung compliance, which is then decreasing their lung volume. If you are having trouble breathing because of Ards or because of any other respiratory problem, you are talking about using those accessory muscles. You are talking about the substernal retractions. You're talking about nasal flaring. You're talking about cyanosis. You're talking about obvious anxiety and dyspnea, tachycardia, diaphoresis. These people are working hard. They might as well be running a marathon, and all they're trying to do is breathe. Changes in sensorium. Of course, decreased mentation, cyanosis, pallor, hypoxemia. We can expect all of those things. Profound respiratory distress. Lots of times we are going to need to intubate these people because we're going to have to put them on a ventilator and try and maximize the amount of oxygen they're getting, but also to give them a rest. They become physically exhausted and unable to rest and or to keep up the pace, because it would be like running a marathon 24 hours a day and not able to sleep or eat or rest, and they get quickly tired out. And even if they don't require full mechanical ventilation, lots of times we can use CPAP. But these people that are on a ventilator, the important part is to maintain a high PEEP, positive end expiratory pressure. Please be sure you know those words, positive end expiratory pressure. And just think about that. Positive pressure, so that means a high pressure, lots of it. End, where is the end of the respiratory, where is the end of inhalation? The end happens in the alveoli where gas exchange happens. So if I have a positive end expiratory pressure, that means that when I expire, when I blow out all my oxygen, I am still going to have air blowing down in my alveoli. And I need the air blowing down in those alveoli because I need them not to collapse. Remember that there's a surfactant dysfunction and that the surface tension is increased. And so if I keep air in them, then they won't collapse until I take my next breath in. In terms of a chest x-ray, we use the term white out or white lung because of the widespread infiltrates throughout. I don't have any pictures or clips in here, but you can go to Google Images and Google chest x-ray of an Ards patient, and you'll be able to see, or Google white out or widespread infiltrates, and you'll be able to see pictures if you are so interested. Nursing assessment. It is going to be critical that you are good at assessing these people, because early detection is the key. If you had somebody who was septic and maybe the root cause was urosepsis, and all of a sudden they start developing these symptoms that they're breathing fast, and that's the key. They have their respiratory rate is increased, They are a little bit dyspneic, maybe a little bit more agitated than they have been. Their breathing is a bit shallow. Heart rate keeps going up. You gotta really be your patient advocate and start looking at what's going on. And we said initially, take a look at these symptoms. Shallow breathing with increased respiratory rate. J receptors were stimulated in the alveolar interstitium, and they were stimulated because of pulmonary edema. And so what did it do? It increased my respiratory rate. Well, even before the J receptors were stimulated, if I'm not getting enough oxygen, I am going to increase my heart rate. My heart rate is going to increase because my tissues are asking for more oxygen. Well, eventually, as the J receptors kick in to try and take over, the respiratory rate keeps going up. But we know that when the J receptors are stimulated, we're going to have bradycardia and hypotension. So initially, in terms of trying to maintain homeostasis, we can increase respiratory rate, increase heart rate, and increase blood pressure. But once the pulmonary edema gets bad, J receptors kick in, we have increased respiratory rate, hypotension, and bradycardia. Of course, we can expect to see changes in the ABGs, of course, looking for respiratory alkalosis. When we're talking about respiratory alkalosis, remember Rome, respiratory opposite, metabolic equal. So when I say respiratory opposite, if I have an alkaline number, that means that my pH is alkaline. That means that it is high. I would expect CO2 to be low to give me respiratory alkalosis. Oxygen therapy, things that we're going to do for these people. We are going to put them on oxygen. Lots of times, initially, we're going on 100% rebreather. We're trying, of course, to give the lowest concentration that we can. We want to maintain a PaO2 greater than 60 and constantly monitoring the O2 sat. We said before that we were going to maintain a high PEEP. I've given you here a slide to talk about PEEP and how high levels can help this person so that they don't get atelectasis, so that the alveoli do not collapse. And I don't think it's necessarily, I don't think you need to memorize in there. I gave you a lot of detail for those that are interested. You will have a whole lecture coming up on mechanical ventilation, in which case you will understand PEEP in much greater detail. But I did, because you haven't had that lecture, I did put a couple things in here. I would never test you on measurements for PEEP or anything like that. You would never, as a basic nurse, as an entry-level nurse, you would never be expected to do anything with the ventilator. That's not to say that you would not care for a patient with a vent, but you would not be expected to understand, manipulate, or do anything else to a ventilator until you had a critical care course in which you were introduced to all of these concepts in much greater detail. Positioning strategies. I think that this is one of the things that is a little bit different than some of the other illnesses that we have, and positioning is really important. We have a position that we call prone. So when you're supine, you're laying on your back. When you're prone, you're laying on your stomach. Well, we also know that when we have fluid building up in the lungs, even though it's diffuse infiltrates all over in there, the fluid tends to accumulate in the dependent areas. So the dependent areas are going to be, you're kind of laying on your back and you're kind of sitting up a little bit, the head of the bed is elevated. So the back, the alveoli towards your back, towards your spine have more fluid, and the alveoli in the bases of your lung have more fluid in it. So we try, and some people respond to it, we try a positioning technique called proning, in which we turn the person over on their stomach, and what we're trying to do is to move fluid and to improve gas exchange, to make gas exchange happen in the alveoli that are still less congested. So I think the next picture here, I'll show you a picture in a second of proning. Now there's all kinds of different things, and not everybody responds to it. but it is definitely worth trying. That is one of the things that you would do immediately. Most hospitals will have beds that will actually move the people, and some of them have continuously rotating, like lateral beds. The person never has an area that is dependent because the bed is constantly moving them side to side. You see here in this slide actual pads that they're putting. The patient is on a ventilator, and anytime a patient is on a vent and intubated through their mouth, the patient is usually sedated because it's very difficult. They feel like they're choking, and it is very uncomfortable. So in this picture, this is the old-fashioned way, strapping something around the patient's waist as well as their chest and laying them on their stomach. The nurse always stays with the patient when we're proning them like this because clearly they're very vulnerable. Okay, what do we need to do for these people? Well, other than stopping the inflammatory response, which in this case, if its most common cause is sepsis, let's get the sepsis under control. So let's get the infection under control, and then maybe everything will settle down. Well, we do need to maintain cardiac output and tissue perfusion because, as we said, if they're not doing gas exchange, we don't have tissue perfusion. We're going to have difficulty with cardiac output because we have pulmonary hypertension. And we have pulmonary hypertension because we have all those teeny weeny blood clots in the vasculature around the alveoli. So the blood comes out of the right side of the heart and it tries to get to the other side of the heart, but it's got to really push against a great amount of force to get over there. So we are going to want to maintain cardiac output. We want to maintain tissue perfusion. We are constantly looking at blood pressures. These people, we are going to want to have a pulmonary artery wedge pressure. They call that PAWP, P-A-W-P, to measure exactly what is happening in there. We can't just rely on blood pressures at that point. We need to look directly at the person. Use of ionotropic drugs may be necessary. Why might they be necessary? Well, because we might need some vasodilation in there. We might need some increased force of contractility. We're going to want to make sure that we have a hemoglobin that is greater than 9 or 10. Because if our hemoglobin is low, our oxygen carrying capacity is low, and we can't have a low oxygen carrying capacity in addition to poor ventilation. So we might give them packed cells, maintenance of fluid balance. That's going to be important. We said in sepsis, something that's going to lead the person down the trail of MODS is that we have all that fluid leaking into in this case, alveoli and out of the capillaries into the interstitial space, which then is having less circulating volume. And if I have less circulating volume, I have no chance of perfusing those end target organs. Again, the ultimate thing is treat the underlying condition. If we don't treat the underlying condition, we cannot take away this inflammatory response that is happening in the lungs.